do a slow start. I welcome everyone. I would just like to acknowledge the traditional owners of the lands on which we meet, and pay my respects to their elders past, present and emerging, and acknowledge their custodianship of the land and the waterways. And for anyone who's from Aotearoa, tēnā koutou, tēnā koutou, tēnā koutou katoa. It's my pleasure tonight to chair this session, by our speakers. The first one will be Associate Professor David Liu, who's an esophagogastric general surgeon from Austin Health and the Peter MacCallum Cancer Institute Cancer Centre, and Dr. David Walsh, that we all know, who's the clinical director of SAASM and also a general surgeon. It's really gratifying to see what can be done with a prospective peer-reviewed database like ANZASM, how we can actually solve and recognise clinical problems. So I'll leave it to David Liu now to start. Any questions, I think, can be saved until the end, but people are welcome to put them in the chat if they wish, and we'll address them after David speaks. Thanks, David.
Thank you, Prof. And thank you for that lovely introduction. Good to always see you again, either in person or online. And I'll just try to share my screen. And I hope you guys can see this once again. Ebony, you can see that?
Yes, all good.
Okay, great. All right, so thank you, Prof, and also thank you to David Walsh for inviting me tonight to give this address. And I'll be talking about how we're utilising the ANZASM database to understand and address what I'm going to term potentially preventable mortality following upper GI cancer surgery. Here we go, and here are my disclosures. So here's the agenda for the next 30 minutes. I'm told I have 30 minutes to give this speech. So I'm going to break this talk into two parts. The first would be to discuss this paper that we published 2 years ago using the ANZASM database. And then secondly, the second part, I wanted to tell you about a program that we've introduced at the Austin Hospital following this research that we've done to hopefully reduce preventable mortality following upper GI cancer surgery. So I think, as many of you guys would know, or who was online, that upper GI cancer surgery carries a fairly high, relatively high preoperative mortality risk. So across Australia and New Zealand, we're reporting about 3 to 4% post-operative mortality risk. And I've just listed down here some of the more common abdominal-based cancer resections, and OG cancer surgery rates pretty high in amongst all those. And just to put this into a bit more focus, this is the esophagogastric and anastomotic audit, which is an international cohort study commissioned from the UK. And to put things into focus, they reported a 5% 90-day mortality, particularly in low volume centres. And I would argue that for most Australia and New Zealand centres, we're probably low to medium volume. So when we talk about post-operative mortality, there's been lots and lots of research looking at trying to predict post-operative mortality, what those risk factors are, and hopefully how to prevent them. Here are two sort of papers demonstrating this. But really, to my mind, post-operative mortality can be further divided into preventable mortality and non-preventable mortality. And I would argue that it is the preventable component that is particularly important for us as clinicians, because hopefully this is the component that we can address the most. The issue is that we don't really know what the risk factors are for preventable mortality, how to characterize this, and ultimately how to avoid this. And if we have the answers to these questions, then hopefully means that we can implement some quality improvement measures to reduce this aspect of care. And so a couple of years ago, we turned to the ANZASM database to look at this from the lens of an upper GI cancer surgery in Australia. And for those of you who don't know, ANZASM is the Australian New Zealand Audit of Surgical Mortality, and it is clearly initiative that has been directed by the College of Surgeons. And some of you, probably many of you, would have contributed to this database. Essentially, this involves an independent peer review of all inpatient post-operative mortality, and started, I think, in 2001 in Western Australia, and very quickly became nationwide, involving all public hospitals and most private hospitals. All cases have a first-line assessor, and some have a second-line assessor. Really, the aim is to identify clinical management issues. It's not here to assign blame, but it's here to improve care. And so these clinical management issues are then described in terms of their preventability and also their contribution to death. Preventability is broadly classified into three groups: definitely, probably, or definitely not preventable. And contribution to death is also classified into three groups: causative, may have caused, or no difference to the final outcome. And for the purpose of this study, we've defined potentially preventable mortality as any case with clinical management issues that were definitely or probably preventable and were causative or may have caused the patient's demise. And so the study objective here was firstly to determine the causes of mortality following upper GI cancer surgery in Australia, and secondly to quantify the proportion of potentially preventable deaths, and then lastly to describe some of the underlying factors and themes along with these clinical management issues that contributed to preventable deaths. And so we undertook an analysis of this prospectively collected data, as Prof just mentioned, over a 10-year period that was collected. And we looked at all elective cases of upper GI cancer malignancies that underwent surgery, including pharyngo-laryngo-esophagectomies, 3-stage and 2-stage esophagectomies, as well as total and subtotal gastrectomies. We excluded emergency procedures and those cases where there were missing assessor commentary. We defined the complications using what's called an esophagectomy complication consensus guideline. And this is a set of consensus guidelines that have been accepted internationally by our society. And finally, we performed a thematic analysis of the clinical management issues to hopefully gain some lessons learned to be taken forward for quality improvement. So just to give everyone a brief overview of the cohort that we've looked at. We looked at 105 mortalities, including canvassing 636 complications and 123 clinical management issues. So just to give you perspective, to procure 105 mortalities, assuming roughly about a 4 to 5% mortality rate, that's about 3,000 or so esophagectomies that have been done across Australia and New Zealand, which were producing this 105 mortality. Because of the disease, we're seeing more males than females, and the median length of time from surgery to death was 17 days. As expected, these operations are performed in big city hospitals, so most of the death occurred in metropolitan centres, and they largely occurred in public hospitals. This is also a disease of the elderly and the comorbid, and this is a breakdown of these patients' comorbidities. And this is also a breakdown of the case mix with predominant gastrectomies, some esophagectomies, and finally a smattering of pharyngo-laryngo-esophagectomies. So this bar graph shows all causes of mortality that we can procure from this data set. The point I'd like to highlight is that cardiopulmonary complications are by far the most common cause of death following OG cancer resection in Australia. We identified 123 clinical management issues from 105 patients. And then when we looked at the assessors' categorization of their preventability, about 85 of these 123 issues were considered definitely or probably preventable. And about 109 of the 123 clinical management issues were considered either causative or may have caused the patient's demise. So if we put this all together and merge it, we see about 53% of cases that were not preventable, which means, therefore, a staggering close to just under 50% of deaths following upper GI cancer surgery in Australia that were potentially preventable. And so we really want to drill down into this category highlighted in red here to understand the risk factors and also the underlying etiologies and characteristics. This is a complicated table, and this is set in detail in that paper that we published. But just to take you through some key elements here, this is comparing preventable mortality versus a non-preventable group. And the point I want to make is that when we're comparing across baseline characteristics, operative details, etc., really, it's really hard to predict from the outset patients who have potentially preventable mortality. In fact, if we asked, well, we did ask, the database did ask the surgeons who were involved in these cases to grade the likelihood of these people dying, whether they were preventable or not. In fact, those surgeons rated the potentially preventable group as of dying of lower risk than the non-preventable mortality group. What we did find, though, is that in the preventable mortality group, they had a significantly higher number of clinical management issues per patient than the non-preventable group. And in fact, these clinical management issues were pervasive across all three phases of care: preoperative, intraoperative, and postoperative. And what that means is that there were significant opportunities, both in the entire spectrum, the continuum of patient's journey, that were opportunities to intervene to salvage situation that were clearly missed. What we also found was that preventable mortality was associated with much higher number of complications per patient, and these involve things like reoperations, multi-organ dysfunction syndrome, and various other complications. So what this is trying to show you and trying to build now is that preventable mortality is characterized by more complications of varying levels of severity, some more severe than others, but most of which themselves in itself is not catastrophic. But what we're seeing, though, is a snowballing effect, that complications beget complications, particularly in this preventable mortality group. When we came to doing the thematic analysis, and we're looking at this in the preoperative part of categorizing these clinical management issues into themes, we're seeing that in the preoperative phase, there seems to be four main themes that stood out. In disorder or inadequacy in patient workup, treatment delays, lack of senior staff and available resources, and inadequate treatment decision-making. And of these, the recurring aspects are improper or inadequate suboptimal patient planning, assessment optimization fitness, and also inappropriate choice to offer surgery or inappropriate decision to offer surgery at all. In terms of the intraoperative aspects, three themes came out: technical error, lack of seniority of staff, as well as poor treatment decision-making. And you can see here is a smattering of private reasons within each of these themes, and there wasn't a recurring clinical management issue. In terms of the post-operative clinical management issue, they largely fell into the themes of failure to recognize and respond to a deteriorating patient, inadequate or poor treatment decision-making, treatment delays, and also minor communication issues and treatment error. And so armed with this information now, what are some strategies to think about that we may be able to implement to mitigate preoperative clinical management issues? The first thing is, and I'm sure some of you guys will have heard of this before, that when we talk about case selection for cancer staging, we need to start thinking beyond tumor biology. We need to start thinking about patient biology, assessing patients' physical fitness, nutritional fitness, mental fitness for the operation. And increasingly now, we do have validated risk prediction models that incorporates these multifaceted elements into a MDT discussion. So it is important at the MDT not to just look at what does the CT and PET scan show, and can we resect that nodal metastasis? Is that patient actually able to undergo safely the surgical resection in the first place? And closely linked to this is, if they're a borderline, can we optimize their fitness, a concept known as prehabilitation or enhanced prehabilitation? And I'm going to touch on a bit more of this in the second part of this talk. In terms of addressing and mitigating intraoperative clinical management issues, we now have very well rehearsed surgical safety checklists, but we also need highly functioning teams. And this talks about the interaction of the surgical team with the anesthetic team, with the scrub team and the technician team, such that not only do they know about the operation, they know how to work with each other, they also are aware of the theatre resources at that point in place, meaning that in this team, they are able to compensate for errors that may be small, that may snowball, but is able to compensate for it so that the snowballing effect don't happen. It is important for the senior surgeons in these complex cases to be in theatre and not in the tea room or in the meeting. And increasingly around Australia, these are should be two surgeon operations. So I'm not talking about a surgeon and a fellow or a surgeon and a trainee, but two surgeons actually doing the operation, or at the very least, taking over the other surgeon when the case is complex and the other surgeon tires, if anything, to get fresh eyes and hands in the case. In terms of addressing post-operative clinical management issues, it is important that we have the availability of daily review by senior staff, if not in person, at least in contact with the ground crew, with the junior staff, to have and play a significant role in patient management in the post-operative period. Implementing enhanced recovery pathways, and this is an important thing. ERAS pathways are commonly talked about and published in literature as a vehicle to reduce hospital length of stay or improve hospital resource utilization. And whilst those numbers are good to publish on, really, I think in my mind, the real value of ERAS pathways is to lay down a template for when the patient does not progress according to that template. It starts alerting to the team that something should be investigated further, so that we're diagnosing problems early. And this leads to my third point of early detection and rescue ethos. It is important to have that mentality so that the patient in front of us at the bedside, even though they may look quite well, we saw that the CRP, for instance, was dropping acutely very quickly, and all of a sudden it stagnated. This means that we should potentially think about doing a CT scan or a gastroscopy. Early detection leads to early rescue and better outcomes. Within this, we need to have good communication within our units and in between our units. And we've learned firsthand that embedding a cancer care coordinator within the units really help with this communication. So as an interim summary from what we've learned from this paper, we've shown that preventable mortality following OG cancer surgery in Australia is high, close to 50%. And whilst this does require further validation, we are seeing similar trends in other surgical specialties. I think there's been analysis since then at looking at Whipple's procedure, HPB resections, cardiothoracic operations. And we believe that all these findings would improve surgical practice and training, and also help prioritize quality improvement initiatives. Ultimately, the responsibility is on us to prevent what is preventable mortality. And so on this note, I'll take you back to this slide, which I presented 5 minutes ago. This slide really resonated for us, or these findings really resonated for us at the Austin, whereby a significant number of patients aren't worked up properly, and the choices of the operation may not be adequate. And we looked into our own experience, and we understood this was also problems that also happened at our center. So on the back of this, we thought if we can make our patients better going into the operation, maybe and likely we'll get better patients on the other end. And so I'm going to take one step away from talking about mortality and talk about complications, which of course is closely linked with mortality. And that is that in OG cancer surgery, as we know, there is a high complication rate. And when we're doing esophagectomy, we're quoting about a 50 to 60% complication rate. In a stomach operation, a gastrectomy, it's about 20 to 40%. And we know that surgical complications directly infer poorer patient outcomes, particularly cancer outcomes, poor experience, and of course, it's costly. We also know that surgical complications correlate with poor baseline fitness. And unfortunately, as we saw earlier in terms of the comorbidity breakdown, most of our patients present with poor or suboptimal baseline fitness that is only worsened by neoadjuvant treatment, such as chemotherapy or radiation. This graph that is plotted on the right here plots on the y-axis the Charlson Comorbidity Index, which is a composite marker of the patients presenting baseline comorbidities as a score. And we plotted this over a 10-year period of all patients with upper GI cancers that is presented to Austin Health, a center that I practice in. And the lower the number, the lower the Charlson Comorbidity Index, the more comorbidities they have. And what you can see is that over a 10-year period, we're seeing a increasingly more comorbid patient cohort. And this is reflective of the experience, not just at our center, but across Australia. We're having an aging population, and we're dealing with a disease that is affecting an aging population cohort. And so with the support of our consumer group, we looked to improve on areas in the preoperative phase. So we identified physical fitness, nutritional fitness, mental fitness, and early medical optimization as key elements. This concept is known as enhanced rehabilitation. And we put in place a trial called SOCS, Strong for Esophagogastric Cancer Surgery, which is essentially the name of this trial that we put towards at the Austin, implementing a rehabilitation program at the Austin and Olivia Newton-John Cancer Centre, which was sponsored by the Victorian Integrated Cancer Services, which is part of the Department of Health, and also the Austin Medical Research Foundation. And our hypothesis at this stage, when we started, was if we can increase our patients' baseline fitness, then hopefully that will lead to reduced complications and overall improvement in mortality. And this is basically a big program that required a multifaceted, multidisciplinary team involved in not just service delivery, but also in research. This is the implementation trial schema, essentially comparing SOCS patients, 43 patients, to controls. And the SOCS program had two arms. One was a 12-week program designed for patients undergoing neoadjuvant treatment, and the other was a 4-week program for patients undergoing upfront surgery. This program of rehabilitation was fully integrated into existing standard of care. It was supported by fortnightly prehab clinics, where we saw patients undergoing prehab, as well as an MDM dedicated for prehab to troubleshoot patient progress, and also monthly steering committee meetings. But at the center of all this is a cancer care coordinator, initially by Linda and now by Kat Hall, who really was the anchor point for all these teams, as you saw earlier. Just to give you a flavor of what preoperative optimization looks like in a multifaceted way, this is an aesthetic component of prehab, which involved baseline assessment of biochemical function, lung function, echocardiograms, and various questionnaires, some of which is done after prehab as well. We were able to embed a consultant anaesthetist within the upper GI cancer MDM, which meant that we could address patient fitness in addition to their cancer biology. High-risk anesthetic review occurred as soon as the intent for cure was established by the cancer MDM, and really encouraged the ethos of early investigation and optimization, smoking cessation, addressing any chronic pain issues, and the anesthetic team facilitated any shared decision-making for complex cases. From an exercise point of view, all patients received baseline and post prehab cardiopulmonary exercise testing, various sit-to-stand, 6-minute walk test, functional testing, and surveys. Patients were subjected to aerobic and resistance training, some of which is done in hospital, face-to-face, and others are done at home. The idea is to constantly modulate the training intensity based on the patient's fitness level. From a nutritional point of view, patients were assessed using hand grip strength, indirect calorimetry, various biochemistry and anthropometric measurements, as well as surveys. And the dietitians counseled the patient very early on. And based on the indirect calorimetry, which is a measurement of the patient's gas exchange, we were able to calculate their actual metabolic requirements. And we were dosing now to an individual level the nutrition that they require, either orally or, if need be, supplemented enterally with immune modulation nutrition. From a mental health point of view, we assess patients' baseline fitness mentally and post-prehab using a hospital anxiety and depression screening tool, as well as other surveys. The whole idea here is that if a patient breached a certain level of threshold, they were then referred for our psych team for intervention. And the intervention is really focused on ensuring and bolstering the patient's sense of self-efficacy and resilience against their cancer diagnosis, their treatment, and also help improve their ability to undertake rehabilitation. This slide summarizes the key findings from our SOCS trial, with the SOCS outcomes highlighted in red and the control in blue. And what we're seeing is that we were seeing improvements in hospital stay, particularly ICU stay, but overall length of stay, a decrease in hospital readmission rate. We had a staggering fall in malnutrition rate from presentation to post-prehab. We also significantly dropped our cardiopulmonary complication rate, which you recall earlier was the main driver of post-operative mortality following OG cancer surgery. We saw a marked reduction in anastomotic leak rates, and our 30-day mortality rate, although not significant, appeared lower. We on average saved over $25,000 per patient undergoing these operations. And these patients, because they're coming in fitter and going out fitter, they were able to tolerate more anti-cancer treatments post-op, and there were less cancer recurrences in short-term follow-up 2 years. Interestingly, when we actually looked at the effect of prehabilitation and optimization on surgical complications, we saw that prehabilitation significantly reduced minor complication incidence, so grade 1, grade 2 clavin-dindo, but actually didn't have a significant effect on the incidence of major complications. So we were interested in this, so we looked into this a bit further. And what we did was we took all patients who had a major complication defined by clavin-dindo as a 3 or higher in the control group, and also looked at those in the SOX group. And so these essentially comparing only patients who had major complications in the respective groups. And what we're seeing is that those who had prehab, those who were optimized, had much lower rates of intercurrent complications, meaning that there were less of this snowballing effect that we're talking about earlier on. These patients consequently stayed in ICU for much shorter time, and we shaved almost half a month in hospital inpatient stay, with a subsequent significant increase in adjuvant treatment utilization. So what we've shown is that prehabilitation and proper patient optimization and selection in the preoperative period enhance patient baseline fitness, reduce surgical complications, and that translated to improvement in mortality, at least in the long term, particularly from a cancer-specific mortality. And this is what we found, key findings: being able to work our patients up properly, addressing those early clinical management issues in the preoperative period, help improve physical, nutritional, mental, medical fitness. This led to reduced morbidity, particularly cardiorespiratory, and what didn't show, we also saw reduction in liver and renal complications. We were able to give patients more physiological reserve to surmount complications, such that these complications don't snowball, and we don't convert complications into morbidity or mortality. We saw a decrease in hospital utilization and an increase in cancer therapy uptake, and is likely to be cost effective. And so based on this data, which is currently undergoing publication, our PREO program is funded by the Department of Health. It is now part of routine care at the Austin Hospital. But more importantly, these programs have been submitted to the Victoria Integrated Cancer Services OG Cancer Working Group, which has subsequently made the recommendation to Safer Care Victoria. And soon, I believe, prehabilitation is a requirement in Victoria for centres who do deliver OG cancer resections. And so this is my last slide. I'd like to thank a lot of people for all this data. For the first part of the work, the ANZASM staff members, and also for the second part of the work, the SOX team members. And I'm happy to take any questions from here. Thank you.
Thanks very much, David. That's a great example of the audit cycle in action. We have a couple of comments in the chat. Rob says that MBS codes do not allow for 2 surgeons except for esophagectomies. Do we need to make more applications to MSAC or something to get more item numbers?
So that's an important observation. For our gastrectomies, so far we've been doing them as a surgeon plus fellow. For the esophagectomies, it is somewhat centre dependent. I have I'm fortunate to work across 2 centres, one at Peter Mac and the other at Austin. At Peter Mac, we actually have 3 surgeons who do the esophagectomies. But the fortunate thing is that the 3 surgeons, including myself, are employed at substantial EFT that allows sufficient number of overlap. So whilst MBS codes are technically not rebatable for 3 surgeons, the fact that we're employed by the hospital to deliver that level of care, translates to better outcomes for our patients. I would argue that gastrectomies are somewhat simpler, and so having 2 surgeons per se may not necessarily be a requirement. But I mean, I have to say that whilst a lot of this will come to light shortly, the recommendation from Safer Care Victoria and the Department of Health for esophagectomies in Victoria at least will be that we should at least have 3 surgeons considered to do these operations and cross-cover each other.
Thanks. We also have another comment about, I suppose you'd call it expectation mismatch between patient families and the clinical treating team.
So I'm just trying to read the comments here. Would you like to comment on?
Would you like to comment on incorporating the issue of considering goal concordant care in the pre-op MDT meeting, mainly to kind of avoid the issue of mismatching expectations?
Yeah, I think that's a really important point. I mean, obviously we go through a consent process, but the consent really, how much of the patient actually understands the consent is questionable. I think, I mean, I think it's a good aspect to aspire to, depending on how your health service is set up. Again, fortunately at the Austin and at Peter Mac that I work in, we have shared decision-making units, or we have complex care shared decision-making teams, whereby, particularly for the borderline patients, whereby there may be, which is where inherent expectations we see is most misaligned. Those patients get flagged. And in that sort of environment, there is considerable discussion led by sometimes a clinical ethicist at the Austin, or led by people who have an interest in clinical ethics at Peter Mac, who would have those discussions with the patient by themselves, and then also with the team. And then we will come together actually as a team to have essentially a big meeting. To align our expectations. And I think that's been quite useful. Deb Leong, who's an anaesthetist at Peter Mac at the moment, is doing her PhD, just really exploring this area. And I agree, it is a very important area, particularly for the borderline patients where decision making is not clear upfront. I mean, all patients, if you ask the patients, do you want to go for a curative pathway or a palliative pathway? I would say 95% of patients will say, I want to be cured. But that journey of cure is an arduous one at the very best. And it is, I agree, it is hard in a 15-minute consent session to be able to confer all that for the patient. So it's a good point.
Yep. We've got time for two more questions quickly before we move on to David Walsh's presentation. Jonathan Fong asks, how did you build the support to change the system for rehabilitating patients, and what challenges did you face, and how did you overcome them?
Yeah, it's a good question. Thanks, John. Good to see you online, and good to see Tasmanian representatives too, Prof. And so I can really go, for another half an hour on this question, John. But broadly speaking, it was about the right time, right place. I happened to have chaired the OG Cancer Summit in Victoria at that time when we finished that piece of work from ANZASM. And so there was a need. And at the Department of Health level, there was also a calling. Simultaneously at that point, VICS, which is the Victorian Integrated Cancer Service, which is part of a subsidiary part of Department of Health, had a $100,000 grant for service improvement. And so we applied and we were lucky to get that. And that became a springboard for this program. And we essentially ran this program on the smell of an oily rag, so they say. But we were able to run it, and we were able to run it to deliver these results I've just presented. And when we presented these results to the Department of Health, to the hospital, I think the results largely spoke for itself, and hence we were able to get this program built into standard care.
Thank you.
That's the sort of abbreviated version of that. Yeah.
And Stuart Proper just asks, when it comes to rehabilitation, how good is good enough? How long is it reasonable to delay operative intervention while you're rehabilitating someone?
Yeah, that's a very good question, and that's a question actually the Rehabilitation Society, or what we call the ERAS Society, is trying to knuckle down. And there are some randomized trials looking at this very question. This question broadly links to a bigger question, and that is that rehabilitation is sort of a buzzword, but within this, it's actually a very heterogeneous program, with some people offering, say, they offer prehab because of physical prehab, others offering prehab such as ours, which is multifaceted with nutrition, psych, as well as physical. So, in short, it is hard to say. Having said that, though, we are seeing beneficial outcomes in a prehab physical fitness only program with just 2 weeks of physical training. We are seeing benefits from that. As in, that's not our program, but we've seen published literature on this on that short duration. So that may be an answer, at least in this temporary time until we have further data. Is a reasonable delay operative intervention? Well, I think this is why we do a post prehab assessment. We repeat our CPET and various other assessments, because we do believe that if you're not fit going into an operation, you probably shouldn't be having an operation at least at the very least, because there's always another out. Okay, so if you're not fit for an esophagectomy, even after prehab, it is probably better that that patient undergoes, for example, definitive chemoradiation, as an example. Because what you don't want is to be in a situation where the patient has incurred such great morbidity that they can't actually get cancer treatment. And that's probably sort of winning the battle sort of thing, but losing the war. So I think it is important to reassess the patient, and if they're not fit, don't sort of be trapped in, oh, we just need to operate, because you don't. There's often another pathway.
Great, thank you very much. In the interest of time, we'll move on to David Walsh now, and we'll have some more questions at the end.
Has that come up, and can people hear me?
Yep, all good, David.
Okay. I'm going to talk something along the line of complications that fits in reasonably well with David Liu's presentation. I'm actually going to talk about some of the things that are hidden in our ANZASM audit process, and look specifically at some data from the local audits of South Australia and Tasmania that are hosting this seminar tonight, or this webinar. And I'm not going to talk about non-surgical complications as such. If you actually Google that, you sort of get pneumonia and DVT and urinary infections. But I'm actually going to talk about the complications that fit under what's becoming a really important concept of non-technical complications, and particularly how we interact with those involved in a patient's surgical care that are not necessarily the treating surgeon. And you can see from David's talk that it's really a team that gets good results. And I'm just going to look at some of our data that shows how well we are doing with that, and a couple of issues that I think we should deal with. I guess a lot of people here will have been involved not only in doing surgical case forms, but we've been very lucky in ANZASM to have our workforce and the fellows to be heavily involved in actually undertaking assessments. And I think that's one of the strengths of our audit. And if you've had the opportunity to fill in a clinical event, or what we call a clinical management issue, which is not an error, but is, I guess, a point of where there is a possibility to have done better, or a point of learning, then the thing that we ask at that point is for obviously a description, but we have a level of classification, which is consideration, concerns, and adverse events. We try and put the impact upon the patient's journey, and try and put it in relationship to how it impacted the death. We try and put a guide as to whether that was preventable or not. But we also come down here to this drop down, which I'll just blow that up a little bit. We actually ask each surgeon undertaking the assessment whether they felt that it was directly with the treating surgical team, the audited surgical team, or we allow them to suggest that there was another clinical team, probably within the hospital system, that was involved, or there was administrative or problems within the hospital, or there was this other group which sort of takes in things outside of hospital care, or non-medical specialists, and that's sort of nursing and allied health. Now, we do submit, or we do present this data. It's hidden away in things like our annual reports, but it is important to realise that these annual reports are really only distributed to surgeons, and so data about issues and improvements in care for non-surgeons are a little bit hidden within that. As David's also shown, we've had a very good track record of generating a number of publications from our ANZASM data, and that's been going on really from inception. But if you look through the list of nearly 100 publications with our data with various groups, nearly all of them are published in surgical literature, as you'd expect. So again, we keep it closeted sort of within the surgical community. And our case note reviews and our case of the months, which are very popular. People do like a bit of schadenfreude. We like to enjoy the discomfort of others. And we know that within the surgical publications, these are actually read quite a lot. But again, these case note reviews, these stories highlighting an issue, tend only, again, to fall upon the eyes of surgeons. So how many of the clinical management issues in our audits are associated with people who aren't surgeons? So I'd like to present some of that data, and this is the first time that some of this has been dug out and presented. So I'm going to look back in our two states over a couple of years. And basically across SAASM and TASM, we've had about 2,200 cases that have met inclusion for over that time. So we've closed that many cases over those years, and about 17.5% had associated clinical management issues, which fits very nicely with the overall data in ANZASM. And of these cases, about 2/3 were likely to be preventable, and about 80% at least contributed to death. So not insignificant clinical management issues that we're talking about. So of the 418 cases within that 2,200 within our two states, about 420 so had a clinical management issue, and 81 or 19% it was identified that this was not with the audited surgical team. And the biggest group within the non-audited team was another clinical team, followed by the hospital, and the smallest group being other. So I want to just dig a little deeper into that data. And if we look at the other clinical teams, then by far the group that was identified was physicians. The next group was in fact surgeons of another specialty, and things like ICU, ED, and anaesthetics actually make up fairly small numbers within that group. So people like a little bit of colour. So if we look at an example of a problem with another surgical team, this is a patient having elective coronary artery bypass graft, had a bit of a struggle and required a pacemaker on day 2. At that point, it was decided that there would be a transthoracic echocardiogram performed, which was thought to show no issues. And at that point, the patient went out of intensive care. But a few days later, they had a cardiac arrest, a reopening for acute tamponade. And unfortunately, although they survived that initial episode, they didn't survive their return to ICU and died a couple of weeks later. A review of the initial echo done on day 5 actually showed a significant pericardial effusion that had been misreported by the cardiology team. And so that team had a concern flagged against it. And that's typical of a non-surgical clinical unit CMI that we would see in our audit. If we look at hospital issues, the two key events seem to be support, which is really the access to, say, interventional radiology, ERCP, services being available after hours and on weekends. And the second one is that of timely theatre access. And again, typical sort of scenario that would be from this case, an elderly patient is transferred from a rural setting, they've got pneumonia, they have a small bowel obstruction, there's concern that that patient will need support if that bowel obstruction doesn't resolve, so they're transferred to a metropolitan hospital, they're admitted to intensive care, but in fact their bowel obstruction resolves conservatively, and a monitoring femoral arterial line is removed prior to discharge. At that stage, there's a bleed, there's a deterioration, there's a hematoma in the groin, and the patient's unstable. It's after hours, and so there isn't access to interventional radiology, and there is a plan in place to retrieve them to another metropolitan hospital that does have that access, and then ensues an argument over whether the patient will be taken directly to theatre or go to intensive care. That rages for a couple of hours, and eventually it's cancelled. It's now the next day, and there may be interventional radiology available at the first hospital, but by that point the patient has deteriorated and moved to end-of-life care. So communication and access and support were identified in this case. If we look at others, these vary a lot, but they often look at the level of care and monitoring that was provided for a patient, and communication is important. This is an example of a patient who has a number of health issues, basically has a cholecystitis that's managed fairly successfully by percutaneous cystotomy, but at some point the drain's removed and the patient deteriorates, and there is no pathway or a process of identifying who removed the drain and who authorised it. And so that was a concern that our assessors picked up. We know from things like this publication from ANZASM data last year that up to 2/3 of our clinical management issues, or our so-called errors, do relate to non-technical issues. They involve things like decision-making, situational awareness, communication and leadership. And these certainly are the hallmark of those clinical management issues occurring in non-surgical teams. I guess in summary, I'm a little concerned that 20% of our significant clinical management issues seem to be related with groups other than the audited surgical team. And because of the nature of our audit and how we report data, I think that it's likely that 20% is never fed back to the individuals involved. It's very difficult for us at the moment to get feedback to administrators, other craft groups, paramedics, ambulance groups and nurses who don't receive any feedback in the same way as we do as surgeons. And I think this is probably a challenge for the audit going forward, is how do we access non-surgeons? Certainly one of the things we're looking at is being able to access feedback for all surgical teams involved in our patients be they from different specialties. So that's the first thing we can do, and we're looking at that right now. I think we have to be a little bit more specific in our data collection regarding what others are and who we are exactly talking about when we find our CMIs. I think we need to make sure that administrators are given data about the CMIs that we're collecting, and that's something that in South Australia we've worked on quite a lot. But I also think that we need to broaden our sites for publication. I'm certain that most of our webinar participants tonight are surgeons, and so I think we need to target the fact that the data within our audit is not just of interest for surgeons. I think very strongly that we need to get other craft groups into the audit, and things like the first ones in would probably be the interventional cardiologists, gastroenterologists, and those that are involved in procedural work, particularly the radiologists. A lot of this seems to be difficult because of qualified privilege, but in fact, if we are using the data that we obtain in our audit for the purpose of giving feedback and completing the loop of audit, then in fact there's quite a lot we can do with qualified privilege. So I think we need to avoid using that as an excuse and throwing our hands in the air. And the final slide, I guess, is that we need to recognise that our audits that we undertake very carefully and put so much work in are actually about surgical care. They're not really audits of surgery, and they're not just audits of surgeons. And I guess that would be my message from my presentation tonight. Thanks very much.
Thank you so much, David, for that. We have a comment from Rob there saying that need complications, not just deaths in ANZASM. Yeah, so I think, yeah, obviously there needs to be more focus on complications rather than just the deaths, but that's all, I guess.
Yeah, I mean, I think that's true, but I think we're also I think that just I think the same themes and the same problems will be occurring in the patients that end up dying, but they'll also be occurring in our complications and people who have prolonged stays and readmissions. So I think that the themes of that we can identify in the patients that do die, I would be surprised if they're very different in those that experience complications.
Yeah, it's tip of the iceberg stuff. I'm just wondering if anyone's got any local examples of models that work in terms of feeding back to other disciplines. It's very hard to get people together in the one place at the same time, I find.
I mean, I think one of the issues is that if we were to look at just the physicians group, they have their own CPD meetings and point systems, and if you're a physician, I mean, that applies to this meeting tonight, and I think perhaps we probably all need to break out of our little silos a bit.
Yeah, I think that's good. I like the idea of also just making the case of the month more widely available to certain craft groups when applicable.
Prof, I'll just make a comment there. I mean, I think I recognize some of the names in the chat group. I think people like Jonathan, Grace Gold, who's trained for the Austin, would know this, is that at the Austin, we have a weekly audit. Our weekly audit perhaps is a little bit different to some of the other hospitals. And I totally echo David's comments. It's an audit of surgical care, not the surgical unit or the surgeon. And so the way that the Austin adopted this culture is that the audit brings together, we call it DOSTI now. So Department of Surgery and Interventional something. Anyway, basically it brings together surgeons, cardiologists, gastroenterologists, ICU, radiologists, basically anyone that does interventional procedures, recognizing that any surgical patient, even though they're managed under a surgical team, can come across the ICU, can come across interventional radiology, can come across cardiology. And so we have an audit that involves all specialties, and all specialties attend. It can be quite chaotic because there's so many units who present, but what it does do is that it flags common recurring themes, and you'd be surprised how commonly certain themes recur. Things like communication issues, for instance, which I think David had flagged in one of his cases. And perched within the back of this sort of almost whole hospital multidisciplinary sort of audit is the quality and safety team that sort of captures these recurring themes and then develop quality improvement processes that overarches the different departments. So that's sort of an example of, asking for examples. That's an example of how we sort of do at the Austin.
Thanks, David. It's nice to see something from N there saying that the audit tool is very comprehensive. Can we have it in New Zealand? David Walsh, would you like to comment on that?
I'm sure you can have it in New Zealand. I think it's probably really about it should certainly be in New Zealand.
It is the ANZASM after all.
Yeah. It was named with the hope that it would be in New Zealand.
Yeah, I'm not sure of the history on that, but yeah, it'll be somewhere in the archives as to why it isn't. So we've got some other comments from Indra and Chinyun, basically about how things work for serious incidents or mortalities. Heads of units can be invited as a representative, but and also reviews occur at hospital level for serious things. But probably, you're also talking about the lower level sort of complications rather than just the root cause analyses and things. So, yeah.
I'm just looking through the comments. Richard, there's a good comment about the ED and ICU M&Ms, and I think that's I think the idea of all of any M&M that's sort of a secret department M&M or a exclusive club is probably a problem for for anybody. So I think an M&M that's not multidisciplinary has probably got in a modern system has some limitations.
Yeah, at our hospital, we also have a death review committee,
Yep.
which looks at all deaths, including out-of-hospital deaths of patients that have been treated at the hospital. And that kind of acts as a link between various M&M meetings at best. So that's another thing. But once again, that's just for the deaths, not for near misses and things like that. Well, thank you very much to both our speakers, and thank you all for attending. It's been a very interesting couple of lectures, and I think we look forward to more output from ANZASM. Thank you very much.